Go ahead and get started. I want to thank you, all of you, for joining us. This is the first of a series of talks that we've put together to help our colorectal fellows across North America in preparing for robotic surgery training. I think that it's, before we get started, there's a few people we want to thank. First, we want to thank the the Association of Program Directors of Colorectal Surgery, who are the sponsors for the course and for these talks that we're giving. But in addition, we really couldn't be able to do these courses without the help of Intuitive Surgical, and in particular, Chris Sanchez and his team. So make sure when you see them to thank them for this. We couldn't do it without them. It's useful to think about where we came from. Now, we've been doing this course for coming on 12 years. And in that time, we have trained close to 600 fellows over the period of about 80 training courses. And to give you some idea of what that looks like in a typical year, in 2019, we trained about 85% of the fellows in the country in 3 sets of courses, depending on their level of experience. And these are the advanced courses that were cadaveric, in-person opportunities to actually do the procedures independently. And as you know, in 2020, all that got short-circuited, and we really did a trivial number of fellows before we were shut down. And this was really a shame for all of us, but a necessary step for safety. And in 2021, we're now at a place where we are restarting the courses in a modified form. The first set of courses will be in May in Houston, and the second set will be June in Atlanta, and I'm not sure where the July courses will be held. But our plan is to, again, offer the course to all of the colorectal fellows across the country. But let's get into the meat of today's talk. We're going to really focus on the nitty-gritty of setup and port placement and instrument selection, with just a hint towards techniques for anastomosis. The rest of the lecture topics that we have over the course of the next 5 months will go into details of the different procedures, showing different anastomotic techniques and different technical implications of the specific operations. But for today, we wanted to kind of teach a port placement philosophy. For some of you, this may be remedial, we understand, but our focus today is to level set everyone and provide a foundation for those that don't have enough experience coming to this point. And for those that do, offer some technical tips and tricks to get them to the next level. So we're going to start with some very basic things. This is the patient cart display. And most of you probably know what this is, but probably don't use it. Unless you're working only in the pelvis, you're going to use lower abdomen for most things. The settings on the side here define the anatomy that you're going to be working on. And then after that, you're going to select the side of the patient that you're going to be placing the robot. It takes all of about 3 seconds to do. This is, again, selecting lower abdomen for anything that involves the abdominal colon, including a low anterior resection. For APR or rectopexies, then you'd use the pelvic designation. I think it's important to standardize your instruments and positioning. This is my standardization. You're obviously going to pick your own when the time comes for you to be in practice in a few months. These are the instruments that I use typically, and I've labeled the arm with them. I know that Dr. Solomon, who's on the line, typically likes to use a 30-degree scope. You'll find that with the XI system, you really can use either scope pretty effectively in most situations. I find the 0 degree to be a little bit easier for the bedside assistant because they don't have to snake their way get into the line of view. They can come in straight with their instruments. But it's not wrong to use a 30 degree. I just find it simpler to do a 0, and it works quite effectively with very little trouble, other than when doing rectopexies and suturing to the sacrum, or when you're mobilizing behind the prostate deep in the pelvis. A 30 degree up sometimes is helpful there. Pretty uniform in my instruments for my working arms. Otherwise, I typically use a monopolar scissors in my right hand, a fenestrated bipolar in my left, and my fixed retractor is typically a small grasping retractor. But in addition, I'm very particular about how I position the patient. I place them directly onto this orange pad, and this keeps them from sliding. The friction between their skin and the pad is quite high, but I also strap them. You'll notice that there's a strap across the chest. The arms are tucked. There's a metal device that's secured to the table to protect the face and endotracheal tube from the robot arms as you're moving along. Obviously, a warming blanket, protecting the hands, and of course, putting them in lithotomy. And understandably, everyone has their own technique. I'm just showing you what mine is here. It's important to think about the XI arm choreography. The XI arms like to move as a unit. And any of you that may have learned previously on the SI system know that you like to have, with that system, you want to have elbow space between the arms. That's actually the opposite of what we want with the XI system. You want the arms closer together. And in the lower left photograph on the screen here, you'll see how the arms will move as a unit as you work at the extremes of your workspace. They'll fall down like a fan and work together. The worst thing you could do is keep either your instrument tips far apart or move your ports far apart, because then you can have collisions either externally or internally, respectively. In general, putting your arms closer together is better than having them further apart. Now let's spend some time talking about a port placement philosophy. And you probably already aware from laparoscopy that everyone kind of does it their own way, and you will be able to do that for yourself. But it's really helpful to think about how the XI system was designed and how the engineers planned for the ports to be placed. Because if you are able to understand that, then you'll have less conflict in the operating room, less collisions, and less frustration when you have trouble reaching what you want to reach. So the way I approach my port placement philosophy is I ask myself, do I have an anchor? Is there some port that shouldn't change? And because I like to limit the number of incisions, typically for a low anterior in particular, an ileostomy site in the right lower quadrant is typically the anchor for me. For a right colectomy, the anchor would be a phenensteel position, because that will be my extraction site. And those are the points on which I then draw my line of my ports. The second thing you ask after you define your anchor is, what's your workspace? And so for the workspaces, where are you going to be working to mobilize your colon? For a low anterior, that's going to be from mid-transverse colon all the way down to the pelvis, and particularly the right pelvic sidewall. For a right colon, you're going to be going from terminal ilium to the middle coccyx or more. And so once you've defined your workspace, you try to find the linear middle of that workspace. And that's what you typically will target on. And so when the XI system asks you to focus on your target anatomy, that target anatomy is not your pathology, but the center of your workspace. And that's an important concept to keep in mind. After that, you want to place your ports 10 to 20 centimeters away from your workspace and perpendicular to the center of that workspace. So step one, again, is define your workspace. Step two is then to find the middle of that workspace, draw a perpendicular to it about 10 to 20 centimeters away, thinking about where your anchor is going to be. Now put another perpendicular, and that's going to be your port line. And if you've done this properly, when you target, your robot arms should now be in line with where you placed your ports. Now we're going to get into a little bit more detail of this. So this is my port arrangement for a robotic low anterior resection. And again, the center of my workspace is going to be, the center of my workspace is going to be about halfway, between the transverse colon and the pelvis. And that's typically about the left iliac crest. And with that port arrangement, you can work in a 180-degree workspace without any difficulty, without making any adjustments whatsoever. Now, one of the beauties of the XI system is that that's not how, as the limit of your work area. The flex joints, which you use all the time, sometimes without understanding them, allows you to be able to move beyond that 180 degrees laterally. Now, in order for it to be effective, when you do your targeting with your camera arm, you want to place it in the middle between L and E. If you do your targeting with your camera arm to one extreme or the other, you will not be able to get the value of flex joint mobility. Now, the other arms will be placed about a fist breadth apart at the arm joint. And this will allow you, again, to be able to move if you need to go beyond the 180-degree workspace that you define with your initial port placement. Now, when you do flex joint movements, you really don't need to remove the instruments or undock the robot, but it is still a good idea to keep your instrument tips in view as you do it. It takes all of about 5 seconds to do, and we'll show you how that works. So this is a diagram again of the colon and a typical arrangement for a low anterior resection. If you want to mobilize to the splenic flexure, you're going to adjust the robot arms up towards the splenic flexure, starting with arm number 1. And then when you need to work down in the pelvis, you're going to flex joint them back down towards the pelvis, towards arm number 4, starting with number 4. And with that adjustment, you now get about 45 degrees of mobility past that 180-degree point. And that gives you 270 degrees of work. And this is, again, without undocking, without removing any of the instruments. In order to flex, you're going to push the port clutch button, hold it, and then move the arms, just like you would if you were adjusting them when you're doing your initial docking. Now, if those of you that have the table motion and integrated to the XI system, you can actually get 360 degrees of mobility without undocking or removing instruments. And the way to do that is to reassign your masters, because as you get past that extent of your flex joint, your right arm is going to be on the left side of the screen, and your left arm is going to be on the right side of the screen. So you need to tell the machine which arm is going to be which. You'll reassign the masters. You'll adjust the bed as needed. You'll move the bowel out of view, because typically we're in Trendelenburg and in some sort of tilt, and the bowels will need to be moved out of your view to be able to work in that final quadrant. And if necessary, you can port hop, meaning you can put your camera in a different arm if necessary. You can put instruments in different arms as necessary. And with that, now you've got full access to the entire abdomen. And that's, again, without undocking and without doing any significant changes. The second key feature that I'd like to focus on is the patient clearance joint. And this is something I find that people don't know about or don't understand completely. So the default is for the patient clearance buttons to be at the up position to allow the robot to come in over the knees and when the patient's in lithotomy. But once you're in position over the abdomen, you can bring the arms down, and you just need to have about a hand's breadth between the arms and the patient. And what that gives you is extra vertical workspace. And what that means is, so for example, if you're working in the pelvis and you need to get up to the duodenum or to the middle colics or to the IMV, you'll be able to access that without having to do significant changes. This is very helpful when you're taking the IMA or when you're starting your medial lateral dissection, because you'll again not be limited by the position of the arms. So to review, the flex joints give you lateral workspace. The patient clearance button gives you vertical workspace. Now, talking about low anterior resection port placement, again, I start by defining my anchor. For a low anterior resection, there's still a chance for many patients, particularly for cancer patients that have been irradiated, that they're going to need an ileostomy. And so for me, that becomes the anchor, because getting a good stoma site is quite important. And adjusting the arms to that port site is easier than having two incisions too close together, one for the stoma and one for the port, especially when that is also the port that typically is the stapler port, which is 12 millimeters. It just makes logical sense to make that at the point where you'd have your ileostomy. So that becomes my anchor. From that point, I then draw a line towards the midclavicular line at the costal margin. And as you can see by the tape measure that's there, that essentially will face the workspace for a low anterior resection. Now, I like to have my extraction site in a phenocele position, and so I do a direct entry and place a wound protector at that point. I don't like to have my extraction site elsewhere because it tends to cause more pain or increased risk of hernia. The hernia rate at this incision is less than 1%, at least in my experience. And then I utilize this Alexis cap, which allows me to insulate the abdomen and begin my exploration so that all my other ports are also placed under direct vision. So step one was select your anchor. Step two, kind of define your workspace. Step three is do your abdominal entry and insulate the abdomen. Now, the diagrams that I have on this slide are intended for illustration. Typically, you're going to want to measure out your port sites after insufflation, but it's harder to demonstrate that for these presentations. So again, this is the typical LAR port placement that I use. For a deep pelvic dissection, I may have a second assist port in the epigastric region. And with this arrangement, you can easily reach from the anus all the way to the transverse colon. Going back to that diagrams I showed a few slides back that show you the lateral reach with the flex joining, et cetera. Again, starting with an anchor, which is going to be my stapler port and possible stoma if the patient needs a stoma. And that's where the line kind of draws off of. And again, I have my extraction site, usually only 3 to 4 centimeters in length, unless I'm doing an extracorporeal anastomosis for some reason, or the specimen needs to be larger in order to be extracted. Now, there are people that are using transanal extraction. At times, we'll use transvaginal extraction, particularly if we're doing a joint case with our gynecology colleagues. And in those cases, I would not have a phenocele incision, but in the majority of cases, that's my first entry and that's my extraction site. So, when we're drawing our port lines again, you're going to start from your anchor up to the midclavicular line at the costal margin. And it's important, different body habitus will define this line a little bit differently. For someone who's particularly tall and where the work that needs to be done is mostly in the pelvis, if you follow the rules that I just placed, your arms are going to be too close together when you're working in the pelvis. So you need to adjust the line to be, again, facing the area you're working primarily. That may mean moving your arms up to the patient right. You want to be careful not to place arm 1 too superior or too lateral if you need to mobilize your splenic flexure, because you'll be right on top of yourself and you won't be able to use it for much. But again, that you'll be able to work in this entire 2 quadrants of the abdomen without too much difficulty. It's coming up here where you sometimes have to do flex joining at the splenic flexure, or reaching into the transverse colon if you have to, for some reason, do an extended resection there. You want to ensure that your spacing from arms 2, 3, and 4 are such that when you come to work in the pelvis, that you've got enough lateral reach that they're not going to be colliding internally. So again, you need to adjust it based on the workspace that you're going to be working on. And again, having this idea of facing your workspace and allowing for separation between your instruments is important. I typically like to start with 7 centimeters of spacing. Now, in somebody who's obese, that needs to be extended because the distance at the skin, even with insufflation, is going to be very different than the spacing internally. So if you're at 7 centimeters and somebody with a BMI of 40, you're going to have internal collisions. And so you want to go to 8 centimeters. Similarly, if you're doing a procedure on a pediatric patient or a tiny woman, you might want to bring the arms to 6 centimeters apart. And again, the closer together, the better generally, so that you limit the internal collisions otherwise. You'll find that the exercise system is very forgiving, and you can go between 6 and 10 centimeters without too much trouble if you've got enough room to place the ports as you're moving forward. Now, these are the different roles of the different arms. So camera for a low anterior typically is in arm 3. Arm 4 will be my right hand. Arm 2 will be my left hand, and fixed retract will be in arm 1. As you'll have your assist somewhere in the right flank, depending on the area you're going to be working on, to make sure that you don't collide with either the arms or and that you can reach into the pelvis as necessary. These are the instruments that I place into each of those arms. So for arm 1, it's typically simply the grasping retractor, doesn't change very often. Arm 2 is the fenestrated bipolar, and arm 4 will be at times will be the vessel sealer or the scissors or the stapler. These are suggestions. There are people who use different instruments, and Intuitive has new technologies that are coming out all the time where this may change, but this is a relatively inexpensive and effective arrangement of instruments that I found to be very effective over a course of hundreds of cases. And this is just, again, a description of those instruments in general. We're going to briefly show a video of an intracorporeal low anterior resection. Before we start, this is from several years ago. We've modified the technique just a little bit from this, but I think it's still useful to see the value of, again, being able to do an intracorporeal anastomosis. At this point, we've already transected the rectum. We're completing the division of the mesocolon. We confirm perfusion to the point of transection with ICG, and you can see brisk perfusion there. After we've confirmed perfusion, we then make as you can see, we've placed the anvil for the EEA stapler. We make a colectomy on the specimen side. This is the part now that is beyond perfusion. And it's got to be big enough to be able to get the anvil in. I like to use a clip applier to place it in, but you can use whatever instrument you like that works. Once you get it in, you're going to make a second colectomy and pull the anvil through. In this case, I used a purse string, but I rarely feel the need to do that anymore. It is important as you do this to make sure that your tiny colectomy around the anvil isn't too large, but it's really very simple to do a purse string if that's what you like. Alternatively, you can simply transect at this point and put a purse string, then place the anvil like you would for an extracorporeal anastomosis. I really do like the side to end anastomosis, and so this is what I do. Once you've done that, you'll transect the rectum, and then you don't need to undock or redock. You're in position to immediately go to your anastomosis. And you can do that all robotically, which is, again, another value of the robot. This mating of the anvil to the stapler is so much easier intracorporeally than it is with a robot than it is with laparoscopic. So let's switch gears a little bit and move on to a robot right. This is the port arrangement that I use for robot right colectomy. Again, the key points are, number one, do you have an anchor? For me, it's my extraction site, which is in the phenocele position. Second thing is you want to face your workspace. So the workspace for right colectomy is going to be from mid-colic to the terminal ilium. And this port arrangement allows me to remain 10 to 20 centimeters apart, but still face this workspace over here. So step one for me is to define this anchor here, place again, 3 centimeter incision in the phenocele position. This will be my stapler port, and then make a line to the midclavicular line costal margin, 7 centimeters apart. Again, we'll show you that in just a minute. Some people prefer to staple from arm 3 over here, and that's perfectly valid. The difference is that you have to make sure you close that port if it's going to be a 12 millimeter port. And you still need to have, at some point, an extraction site. And some people use this as their extraction site. Again, quite valid. It just tends to be a bit deeper if you've got a obese person, and quite a long incision if you have a large specimen with more pain and higher risk of hernia, in my experience, than if you use a fen and steel position down here. But the nice thing about the XI system is any one of these ports can be your stapler port, and you can port hop as you need to do the work that you need. I just have found that putting the stapler and the specimen extraction in the phenocele position is the most effective for me. When you're doing this, you're going to be targeting to the middle of your workspace again, and that typically is your hepatic flexure. Again, I tend to like to remain about 7 centimeters apart for the vast majority of patients. It is the rare morbidly obese person where I'll go beyond that to 8 centimeters or higher. One thing to keep in mind, if you do have a wound protector with a cap here in your arm 1 position, you probably need to go to 8 centimeters between your port sites to get beyond your small wound protector. That's one exception that you'll need to make in order to not put your number 2 port through your wound protector. I'll typically have an assist port in the flank, and the camera in my experience, I prefer to have in my arm 2, left hand in arm 1, right hand in arm 3, and the fixed retractor I find best to be in arm 4. There are a lot of people who prefer to have the camera in arm 3 and have 2 left hands. It's not wrong. It's just a difference in preference. I have found that the fixed retractor in arm 1 tends to be too close to the cecum, which is where you often are needing to do some fixed retraction. And having it out of the way in arm 4 tends to work better in my experience. Again, these are the instruments that we would use in each of those ports. Again, the stapler and the fenestrated bipolar would go into arm 1, camera in arm 2, scissors or vessel sealer, needle driver as needed in arm 3, and arm 4 remains as the small grasping retractor. I have gone to nearly universal intracorporeal anastomosis for all of my anastomoses. The only exception really is in patients with iliopouch anal anastomoses, just because the number of firings of the stapler gets to be cost prohibitive. But for my low anteriors, for my right colectomies, left colectomies, they're almost universally intracorporeal. And this is a standard a right colectomy intracorporeal demonstration. The new simulator that many of you may have also demonstrates this right colectomy. And I would advise you to practice that on the simulator before you do it, because it allows you to practice the staple insertion as well as the suturing. And so here the colon has been fully mobilized. We've now dividing the bowel. I think in my experience that an isoperistaltic anastomosis is really the most the best that I have seen. You can do a side to end as well. That works well. But the nice thing about the isoperistaltic is you don't have any crossing staple lines. It's physiologic in terms of the stool, and it's easier to scope. If you're doing this for a inflammatory bowel disease patient, it's easier to scope them if you've got an isoperistaltic anastomosis than if you have an antiperistaltic. And here we've stapled the common channel, and now we're closing the common opening using a V-lock. Use a 6-inch V-lock. I like to start on the inside and bury the knot. This is again an earlier video where we had placed a stapler in arm 3, and we were using the V-lock on the outside. One of the things that I typically do now is I really cinch this down well. And as Mark Solomon's going to beat into your brains, you want to place these sutures about 5 millimeters apart and 5 millimeters back, cinching this down. I use this 3.0 V-lock, 6-inch 3.0 V-lock in 2 layers. And I find that works really well. I'm actually going to bring this back a little bit. The key to making sure that you've got this right is that you get from staple line to staple line. I typically like to have stay stitches at either end to be able to manipulate the bowel. Some people put their stay stitches at the ends of the staple line. It really doesn't matter, but a common error that we find is people don't close that back wall and they end up with a hole. And as long as you can ensure that you've gone from staple line to staple line, you'll be fine with this closure. And at times you'll need to cut out your stay stitch at the site where the common anerotomy is to be able to see that staple line at that side. This will make more sense when we get into the lab, and hopefully all of you will be able to join us in the lab to be able to practice this. And again, you'll get a chance to see different ways of doing it. I know Mark Solomon, who's on the call, does it a little bit differently. Bob Cleary, who's also on a call, does it somewhat differently than each of us also. And then finally, this is just a video of the use of ICG for a right colectomy. So this is me double checking after a isoperistaltic right colectomy. And the mistakes I've made here is that I've left my stump of the colon too long. And not only is that poor for bacterial overgrowth, but also you can see that there's a demarcation of that stump. So we restapled it to get rid of that excess. And this is the final slide to show some tips and tricks. Many of these we've already mentioned, but it's nice to have them in one place. Again, think about what port is going to be your anchor to define the line that you're going to place. You want to remain 10 to 20 centimeters away from your target and from your workspace as much as you can. And you want to place the port 6 to 10 centimeters apart. Again, less is more. For the most part, you want your ports to be in a straight line. However, I can tell you that XI is very forgiving and you can deviate from that at times. For example, somebody may have already a colostomy and you want to use that as one of your port sites. And so your line may jag a little bit as it goes up and down. Do be aware that that may create some elements of collision, but it's, like I said, generally pretty forgiving. Remember to place the port line to face your workspace. And don't forget to, if you're going to target, and most people still do, to target from the center of your flex joint on the camera arm. If you're at F or X, you're going to have difficulty being able to adjust the flex joints to be able to reach the right or left. And so by staying in the middle between L and E when you target will help you so that you don't lose that lateral mobility. For those that feel they don't need to target, it does add a few seconds when you're doing it. However, what I have found that it does best is it provides for optimal boom height, so that you're not at the extremes. And I can tell you, I've been in the situation where you needed to get the arm to go lower, but your boom was too tall. And so you had to undock and redock and bringing the boom down. So targeting will really kind of bring you in the middle of that arm height and make it optimal. If you do that, you're not going to get those extremes. The patient clearance joints, again, will give you a vertical workspace, and the flex joints will provide you with increased lateral workspace. And I'm going to end with my view of robotic colorectal surgery, which is, in general, minimally invasive surgery is better than open. Minimally invasive surgery is less expensive than open. We have seen that prior to robotics, really, there wasn't very good penetrance in minimally invasive in colorectal surgery, and that robotics really has increased that. We have demonstrated, and others have as well, that the cost of robotics is equivalent to lap once you've gone through the learning curve, and that the cost comes down with experience. Some of the outcomes that we found is that with robotic colorectal surgery, your length of stay will be lower, your conversion rate will be lower, the rate of intracorporeal anastomosis goes up, and the ability to integrate other facilitating technology like three-dimensional view, as well as ICG and articulating instruments, is improved. And it is a path towards eventual autonomous surgery, which we're not at yet. And finally, I find robotic surgery a lot more fun than laparoscopic surgery. And with that, I'm going to stop. I think we're going to have an opportunity to ask questions. I think you'll be placing your questions into the chat, and we will answer them from there. Let's start with Dr. Cleary and Dr. Solomon.
Excellent job, Amir. I really enjoyed that. For the low anteriors, do you ever need 2 assistant ports, and if so, why?
Yeah, I mentioned that in the presentation. For very low dissections in obese men, sometimes you need a second assist port in the epigastric region to pull straight out of the pelvis, and that allows your flank port to suction if there's a need for suction. To be honest with you, it's only about 10% of the time now that I need to do that, particularly if you use the air seal technology, you can suction without having to worry too much about losing your view. But in obese men, deep in the pelvis, it's nice to have a second assist port.
Great, thank you. Looks like we have 50 fellows participating in this webinar. This is your chance, everybody, to learn from the best. I know that when Dr. Bastaros and I started this in 2011, I have learned a lot from him over the past 10 years. This is your opportunity.
All right, it looks like there's a Q&A there. Joel Calafel, I hope I pronounced that right. Any tips on where is the optimal placement for the assist port? So it depends on where you're working. I think the tricks, again, the philosophy on where to put your assist port is to think about where the robot ports are. Make sure that you're not in line with the robot ports, that you can fit between them. Think about not being too close to your robot ports so that your assistant doesn't get hit in the head every time the robot moves. For me, typically for a low anterior, it'll be in the right flank. Sometimes it'll be lower down, particularly in somebody that's tall, so that you can get beyond arm 4. For a right colectomy, the left flank is just fine. It's rarely a problem. In fact, your assist doesn't do much other than bring the needle in and out, and sometimes it'll suction for you. When I do a total colectomy, I put 5 ports in a straight line, and the lateral port typically will be the assistant port. I don't have table motion, so I undock and redock, moving the robot to the upper abdomen and the lower abdomen. The ports are in a straight line across the abdomen infraumbilically. Michael Rouse asks, how does your port placement vary for APR, particularly for a small male pelvis? So APR, not gonna need to mobilize the splenic flexure. And so I will place my ports in a transverse line. Um, uh, Again, thinking about where my anchor is. So for an APR, my anchor is gonna be the colostomy site, and that'll be my stapler site as well. And so that'll typically be my arm 4. And for most people, that's going to be the left lower quadrant. And then I measure out from there across to the right lower quadrant, facing the pelvis primarily. Jason Chen asks, could you reiterate what you meant by avoiding too long of a pouch in making your isoperistaltic anastomosis and bacterial overgrowth? So when you do any kind of an anastomosis, what you don't want is to leave more than 2 centimeters where there isn't flow of stool. So when you perform your anastomosis, and again, for isoperistaltic anastomosis, or if I do a side to end low anterior anastomosis, you want to make sure that from the common anastomotic opening to the staple line is not more than 2 centimeters. If you do, you risk having bacterial overgrowth. I have seen situations where that can cause perforation of the staple line. You can have similar symptoms like with small bowel bacterial overgrowth. You can have some dumping symptoms. You can have diarrhea and other complications. So you don't want to be more than 2 centimeters. I typically try to stay only about 1 centimeter. Nicholas On asks, what port position would you recommend for a total? So we're going to have a whole talk on total abdominal colectomy later in this series. My answer is that I've done it in 2 different ways. In some patients, I've done a diagonal from the left upper quadrant to the right lower quadrant through the umbilicus. But what I've moved to for most people is a transverse infraumbilical orientation basically from the right flank to the left flank infraumbilically. And that puts camera just about at the level of the midline infraumbilically. And when I do my totals again, because I don't have table motion, I'll start with the lower abdominal dissection, including the sigmoid colon, the IMA. Oftentimes I can also still reach the IMV, the cecum, the terminal ileum, the rectum, if necessary. Once I've done all of that, I then undock, move the robot to the other side, and then do the reposition the patient, get the bowel out of the way, and do the upper abdomen, utilizing the same ports, now facing the upper abdomen, and do the flexures and the middle colics. I find that works better, particularly if you're not too high. If you place it at the level of umbilicus or supraumbilical, you're going to be right on top of your middle colics, right on top of your transverse colon, and not be able to work in that position. So I prefer to go transverse if I can. For a very small person, you may need to adjust that angle, slightly. Jonathan Dameworth asks, thank you for the talk for right colectomy ICA. How far from the small bowel and colon staple lines are you making the anerotomy colotomy? So I do isoperistaltic. So you're only going to be 1 centimeter away from, typically in my hands, the small bowel staple line. So that's where you're going to make the anerotomy. The colotomy, I use a 60 millimeter stapler. So I try to make the overlap to be at least 60 millimeters. That's usually sufficient. And if you measure out 60 millimeters and use a 60 millimeter stapler, you'll end up with a 45 to 50 millimeter anastomosis. Joseph Riyad, for intracorporeal LAR, do you pass the anvil without a spike? Yes, and that's because I am totally incompetent in trying to remove that spike, whether open, laparoscopic, or robotically from the anvil. Plus, also, you don't really need it since you've got an open colon that you're placing the anvil in. And I just make a small colotomy to bring the end of the anvil out. Trevor Teeter asks, how do you increase workspace on a small patient? Do you ever break the bed, extend the back? Yeah, those are really good little tricks. I don't usually have to do that. Again, if you have a really small patient coming into 6 centimeters between your ports is usually enough. Depending on the operation you're doing, you can also make more workspace by moving further away from where you're working. And that may be altering the arrangement that we've described here. Again, the XI is very forgiving. And this is where having a philosophy of port placement is helpful. So thinking about being 10 to 20 centimeters from your workspace, thinking about the spacing of your instruments, those are all keys. Thinking about anchors, those are the keys to make you successful when you're working in a small space. You'll find that, you know, I've done 12-year-olds, total colectomies on 12-year-olds, and you'll find that you're able to actually get a lot of work done with the XI at 6 centimeters apart. Cynthia Tom is asking, when closing the common channel in a right colectomy, when creating the anastomosis, where is the most common area that we need to be sure to assess to make sure the enterotomy is completely closed? I remember this was mentioned in a lecture I was previously in, but can't remember. So what happens here is that if you're going to close this common enterotomy with suture, you have to make sure that you suture all the way from staple line to staple line. And however you do that is going to be up to you. The way I like to do it is I cut out my stay stitch at the proximal end, and I start at that back wall, essentially back wall staple line. I start there and then work my way away, and then put a second layer of the closing stitch coming back to that spot. I know that Dr. Solomon likes to put stay stitches right at the staple line on both sides. And in that way, and he, I think, starts at the far end staple line and then comes back. It doesn't really matter as long as you ensure that you go from staple line to staple line. The mistake we see every year in the lab is that people either don't see that back wall or start at the far wall, and then the back wall gets buried deep inside and they don't cut out their stay stitch, so they can't see the back wall that they got to the staple line. And sometimes also we'll notice that people will sew down to the posterior staple line, actually closing off their lumen that way. So I like to start proximal at the staple line, work my way distal, and then come back again. Aylin Rogers, I hope I pronounced that right. Really enjoyed your talk. I've worked with some surgeons who use the endoscopic stapler, endo-GI rather than robotic, because they don't trust the robotic stapler. What's your experience with robot stapler with regards to malfunctions? I really have seen fewer malfunctions with the robot stapler than with the laparoscopic staplers. I really would trade much of that for the control that it gives you as the surgeon. It is not wrong to use the endo-GIA or other mechanical staplers. It is less expensive in some situations. It depends on the number of firings and the contracts that you have for the stapler devices. I trust the robot stapler. I trust it particularly deep in the pelvis, and I don't have any problems with malfunction. I think I've had one or two malfunctions with the robot stapler in the 7 years since it's been out. Bob or Mark, do you have anything to add to that point?
No, it's a good point, though. I also trust the robotic stapler. We had planned on comparing them just for the sake of the comparison, but to use the laparoscopic stapler, you have to unhook the arm and put it in through the stapler port. It's nice to be able to do the stapling yourself and in the spirit of operating with 3 arms, but I don't feel too strongly, and I too trust the robotic stapler.
You know, one thing that the robot stapler provides you that most of the other mechanical stapling devices don't is the computer-aided stapling. It won't let you staple if the tissue is too thick, and that's something that unless you have computer-aided technology, you're going to miss out on. Alton Sutter asked about pore placement for a total. I think we answered that earlier, but again, I typically would use a transverse infraumbilical port arrangement. Bob or Mark, what do you do for a total?
Yeah, I learned from you on that one a year or two ago. I also use a transverse arrangement as you described.
Samuel Heathcote, when you do your intracorporeal anastomosis for an LAR, how far away do you make your large colotomy from the small one? So I do it in sequence. And how far from the ICG line do you make the larger colotomy? So I make the large colotomy in the specimen, and that's got to be at least 3 centimeters in order to get a 28 millimeters device in. Once I place the anvil in and I get it well past the transection line of the ICG, I then make a tiny burn with my left hand to get the anvil through. So that's typically going to be about 3 centimeters from that transection point, because you figure you need 1 centimeter separation from the transection stapling to the EEA stapling so that you don't overlap that staple line, plus half of the 28 millimeter, which is going to be 14. So, 25 to 30 millimeters from the end of your transection. In this case, I would tend to be a few millimeters longer because that's less of a risk than being too close and having your transection overlap with your EEA stapler. And I typically make the ICG demarcation the point of transection, and I'll recheck it after I've transected to make sure it's still perfused. Joseph Riyad is asking, in right colectomy, does putting the stapler in arm 1 in the suprapubic make the angle of intracorporeal odd? Odd is a right word. It is a little bit challenging, and that's why I use my stay stitches at the ends of the bowel of the overlap so that I can rotate the stapler to be able to, rotate the bowel so that the stapler is coming in line. I have yet to have a problem where I couldn't staple from the suprapubic position. If that's something that is bothersome to you, just put it in, make your stapler port arm 3 or arm 4 and come across. But again, I like to limit the number and size of my incisions, and it just makes sense for me to have it come in from below. You should be able, if you've mobilized your small bowel sufficiently, and small bowel is freely mobile, you should be able to rotate your overlapped anastomosis 90 degrees if you need to be able to fire your stapler. So odd is the right word. It's not difficult. It does take a little bit of practice to be able to make it happen, but it works just fine. Joel Colifel says, how would your port placement change for a left colectomy? Let's say for a splenic flexure mass. So that's a great question, and something that we've been moving more towards. I basically do a mirror image of a right colectomy. So I'll start with the phensteel position and then go up to the right midclavicular line. And then you're facing again your whole left colon and your splenic flexure and your transverse colon. It works remarkably well. Anthony Donalo, great talk. Thank you. How do you set your ports for splenic flexure mass? I think we just answered that. And Gotham Chitragari, I hope I said that right. I'm sorry if I mispronounced it. Really enjoyed your talk. Can you please explain how you get more lateral reach using flex joints after targeting between L and E? So if you never move your flex joints, you'll get 180 degrees worth of work. But what the flex joint allows you to do is the ability to move the arms with the instrument still in place and reach up towards the splenic flexure to give you another 45 degrees of reach in the right and left orientation. The way to do that is only going to happen if you start off in the middle of your flex joint. And then as you get to the extreme, as you're, for example, working, you've targeted to your iliac crest, and now you're coming up towards the splenic flexure, and your arms are coming like this. What you can do is then move those flex joints, all of them in line, so that now you're facing up towards the splenic flexure, and that'll give you another 45 degrees. Again, when we get into the lab, we'll be able to show this to you more easily than we can here with slides. Maybe I'll try to videotape it, so for a future presentation, we can show you how that works. It's really pretty trivial. The tips of the instruments don't move. You don't need to undock. You just need to clutch the port and move them in order from the most in the direction that you're going. So either from number 1 or number 4. Anonymous says, thanks for the talk. Is closing the enterotomy after the isoperistaltic anastomosis possible with 1 layer? Absolutely. And there are people who do it in 1 layer. I feel more comfortable doing it in 2. That's just how I do it. Let's see here. There is a chat here as well. It's just more correct to use a 30. Of course, Solomon will say that, 30-degree scope. I don't think it's wrong. When I do laparoscopy, I use a 30-degree scope. I just find that it's easier for my bedside assist to use a 0, and I'll use a 30 in very limited scenarios, and it works just fine. That's all I've got. Bob, do you have anything you want to add?
No, really well done. It was an excellent educational opportunity.
Thank you. We have one more question. Do you still do an intracorporeal anvil placement for LAR if still using a Fenton steel? Yes, my Fenton steel is much, much smaller than if you're doing an extracorporeal anastomosis, because you don't have to mobilize your colon quite as much. My Fenton steel is really, it's 3 to 4 centimeters maximum, just enough to be able to get the specimen out and get the anvil in. So yes, I still do a use of Fenton steel, and that's how you get the anvil in. I used to try to place the anvil through the stapler port, and I found that was cumbersome. You had to undock the port. It often was too small to get a 28 millimeter anvil in. So you need to have an extraction site anyway. I like the Fenton steel for the extraction, so that's where I place the anvil. There's nothing wrong with doing an extracorporeal anastomosis, but just be aware that you typically, especially in the obese person, that incision is going to be longer than it would be just to place the anvil for an intracorporeal anastomosis. And I found that the ileus and bowel recovery is much faster if you do intracorporeal in general. Is it possible to do extracorporeal anastomosis in right colectomy using Fenton steel? That's challenging because getting the transverse colon out through the Fenton steel is, you have to do quite a lot of mobilization. And when you do that, you kind of obviate the value of doing the robotic surgery, I found, and getting it to reach is very difficult. Joel Calafel says, with a small extraction port, do you use an endo catch bag? Sometimes, depends on the indication for the surgery. Any tips to make it easier? I'm not sure what that's referring to.
Amir, I think we've found that in the studies that we've done together, that though it's the extracorporeal right colectomy is more common for the laparoscopic approach, the intracorporeal technique has become more common for the robotic approach.
Yeah. I think this will have to be our last question because we're at time here. Robert Melizia asks, when doing a robot J pouch, do you create the pouch intracorporeally? So that's something I really want to do, particularly now that we have a 60 millimeter stapler, but I haven't done it yet, only because it gets expensive. In order to do a robotic J pouch, you need to fire 1, 2, 3, 4, at least 4 times, and typically 5 or 6 times. And the cost of 6 firings is so expensive that it sometimes isn't worth it. But in addition, if you're going to do your extraction, sometimes it may be difficult to get the extraction out through the stoma site. You can take it out through the anus and do a purse string at the anal stump. But as of right now, I've still done an extracorporeal through a Fenton steel to do the J pouch because mostly because of cost. Bob, have you done any intracorporeal J pouches?
I have, but my humble impression is that unless you do a lot of them, it takes a long time.
Yeah. I mean, I really want to do it. I think it would be it would be nice to be able to create it all intracorporeally. I just find that it gets to be so expensive. You know, I think it isn't much to make a 3 centimeter Fenton steel to make the pouch using a standard GIA to create your pouch that way.
I concur.
Just because you can doesn't mean you should. All right. I want to thank you all for participating. I hope this has been valuable. We really, really look forward to meeting all of you at our courses. We are starting in May in Houston, and then June in Atlanta. I think there's going to be some July courses as well, and I'm not sure where those will be held. Please all be safe. Please continue to attend these. We have a lot of people putting a lot of work in trying to resurrect this course. These are topics that we typically would give on the dates of the lab, but we're trying to expand to give you time to experience the year-long course utilizing these newer technologies. So thank you all for participating. I hope it's been valuable. We have recorded the talk so that you can review it later, and we'll likely post this on the program director's website so that it'll be available to you there. Thank you all. Have a good Sunday and see you soon. Be safe.